Yes, Priyadarshini,
Yes, sir.
but you are live on YouTube now.
Okay, sir. Yes. Hello, my dear nursing students. Am I audible? Yes. If I'm audible, please update in the chat box. Yes. Am I audible, dear students? Yes. Thank you so much. Yes. 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 Okay. So, a very good evening, everyone. This is Priyadarshini, your mastermind faculty at Nursing Next Live. I welcome you all to the Plan MSc Live previous year paper related session. Right? So, in this particular session, we're going to specifically see about medical surgical nurse MCQs and nursing management MCQs. And the most important thing is your 2025 AIMS recall questions are going to be discussed here, right? Your 2025 AIMS recall questions are going to be discussed here. And I think you all are already aware about this particular notification. The admission notice for BSc nursing and MSc nursing is already out, as you all know. And note down these dates. These dates are very, very important for your upcoming MSc nursing entrance examination. So for MSc nursing, you can see here. So the starting date of the application entry is 17/4/2025. Okay. So 17th April 2025, your application registration is going to start, right? And the closing date will be 15th of 15th of, okay, 15th of May, right? Yes. Application is going to start at 17th and it's going to end at very important to note these dates. Tentative date for MSc examination, it is 20th June. Date will be announced in 27th. Now you are at the end of March, so it's April, May, June. So max to max, you have 2.5 months, and within that, if you're going to do a proper preparation, you can definitely achieve your entrance examination of MSc nursing and you can enter into your dream college, right? Doing masters in reputed college is again a very, very important aspect, right? So these are the important information which I'd like to disseminate for you people. And let's enter into the session. I want you people to actively answer in the chat box so that we can analyze your proficiency, right? So the first MCQ which we are going to discuss. So the first MCQ is the patient is assessed using a Glasgow coma scale, right? The nurse observes that the patient open eyes only to painful stimuli. Okay, the patient is opening the eyes only to the painful stimuli, and he's obeying the command for movements and uses inappropriate words, what is the total GCS score? This is your last year AIMS question. Okay. So to solve this, let's discuss about GCS first. Okay. So we have three components in our GCS, as you all know. We have, okay, your eye component, right? Your eye opening and your verbal response and motor response, right? Verbal response and motor response, right? So the maximal score in eye opening, as you all know, it is 4, right? The maximal score in your verbal response is 5, and your maximal score in motor response is 6, right? So starting from the maximal score 4, if there is a spontaneous eye opening, then you're giving the score of 4, right? If the patient eye is responding to speech, then your score is going to be 3. And if she is responding to only pain, then your score is going to be 2. If there's no response, right? If there is no response, then your score is going to be 1. This is a very, very important point you people have to remember. Always remember, DCS is not a 4 or 0. Each, right? The patient score only to painful stimuli. So it is open like only, then the score is what? If the patient is pain, praise, and is confused, I'm not aware of where is what. Yes, there was an interruption in the Wi-Fi. Okay. So let's continue. For verbal response, the maximum score is 5. If the patient is oriented, then we are giving the score of 5. And confused, we are giving the score of 4. And inappropriate words. Okay. If showing inappropriate words, then you are giving the score of 3. Then, if she's giving only incomprehensible sound, then your score is going to be what? 2. When there is no verbal response, then you're going to show the score of only 1, right? So what about the motor response? In motor response, right? So next we're going to see about motor response. So coming back to our question and the verbal response rating. So patient opens eye only to painful stimuli. So we have given the score of 2 for our patient as per our question. And next we have obeys hands for movements. So whenever you are telling something, the patient is obeying for movements. So then here they are talking about the motor response, right? So now we are going to learn about motor response. In motor response, what are all the concepts? We have 6 components, right? And the maximum score is 6. So if the patient is obeying commands as it is given in our question, then it's going to be what? 6, right? And if the patient is localizing pain, okay, is localizing the pain, then your score is going to be 5. Then in motor response, he is doing withdrawal to pain. So then we are going to give the score of 4, right? And if he is doing abnormal flexion, then your score is going to be what? 3. If he is doing abnormal extension, then the score is going to be 2. And if it is no response in motor aspect, then you're going to give 1. So here it is given obeys the commands for the movements. So the maximal score we are going to give is the patient is obeying the command. So with respect to our patient, it is 6. So next, and uses inappropriate words. So come back to inappropriate words in verbal response. Yes. If the patient is using inappropriate words, trying to explain certain things, then the score is going to be what? 3. So what is the GCS score of this particular patient? It is E2, V3 and M6, right? It is E2, V3 and M6. So let's calculate the total. 2 plus 3, 5, 5 plus 6 is equal to 11. So this question answer is 11. So very, very important to know all the aspects of GCS and what is the maximum scoring and what is the minimal scoring, right? And now considering the patient is going for coma, right? If the score is going to be less than or equal to 9, right? Yes. Right? So the next question we're going to see. So a patient is in an emergency department, has a systolic blood pressure of 50 mm of Hg and diastolic blood pressure of 40 mm of Hg, right? And what is the mean arterial pressure for the particular patient? So now the question is asking about the mean arterial pressure. These formula-based questions were also previously in your examination, in your AIMS 2025 entrance examination, MSc entrance examination. Now tell me the answer. What is the mean arterial pressure, or what is the calculation of your mean arterial pressure? What is the formula? So first and foremost, it is very, very important to know about what is mean arterial pressure, right? So the arterial pressure is the average pressure of arteries during a cardiac cycle, right? And this mean arterial pressure is the representation of the tissue perfusion. Well, the organ is perfused, good amount of blood, right? How well the organ is perfused with a good amount of blood will be measured with the help of your mean arterial pressure. Right. So here for mean arterial pressure monitoring, that is the average pressure in the arteries during one cardiac cycle is measured. And this is clinically indicating and representing the tissue perfusion pressure. Right. So what is the formula for calculating the mean arterial pressure? Remember the formula, the mean arterial pressure is equal to your diastolic blood pressure, plus 1 by 3 into your systolic blood pressure minus your diastolic blood pressure, right? So this is the formula to calculate your mean arterial pressure. Okay. So now with the given data, we are going to calculate our patient's mean arterial pressure, which is expected in the question, right? So you can answer in comments also. Yes. Very good, Pavandeep. Very good, Naila. Very good, very good, very good. You are like pro students, right? So your diastolic blood pressure is 40 plus 1/3 into systolic blood pressure is 50 minus your diastolic blood pressure, right? So the calculation is what? 40 plus 0.3, sorry, 0.40 plus, if you want to break it down, I can break it down also. 1/3 into 10. So that is 40 plus your 3.33 is equal to 43.33, right? So if it is 43.33, the most suitable answer is A, as the students have given in the comment box, right? So very good for the winners who have answered correctly. So next, and there is other aspect also, like mean arterial pressure. The other presentation also we can do, the formula presentation, right? So anybody can put in the comment box, what is the other formula presentation of your mean arterial pressure? Other formula presentation includes your mean arterial pressure is equal to your systolic blood pressure plus 2 into your diastolic blood pressure divided by 3. This is another formula. Both the formula are same. Just on solving this particular formula, you will get this formula, or solving this particular formula, you can get this particular formula, right? But you have to remember both the formulas, or you can just remember only one formula. That's more than enough. Anyway, both the formulas are going to give you the same answers, right? So the next question we are going to see. Okay, let me put a question for you people. Like, what is the normal mean arterial pressure? Right? Tell me what is the normal mean arterial pressure in the comment box. What is the normal? Like Pavandeep, Naya, tell me what is the normal mean arterial pressure? So your normal mean arterial pressure is 70 to 100 mm of Hg. 70 to 100 mm of Hg. So while you're seeing our patient who is having 43 mm of Hg, it is drastically less, right? If you're telling in what case, what is the actual range you have to remember while studying about mean arterial pressure? See, remember, when mean arterial pressure is less than or equal to, okay, less than or equal to, less than or equal to 60 mm of Hg, then you're telling the patient is having a very poor organ perfusion, right? Which means adequate amount of blood supply is not reaching the functional organs. Okay, so this particular reduced amount of mean arterial pressure can risk the patient for renal failure. Okay, and the primary reason you know about AKI, that is your acute kidney injury, pre-renal acute kidney injury. What is the reason for pre-renal AKI? As you all know, pre-renal AKI primary indication is lack of perfusion to the kidney. So when the overall mean arterial pressure of a patient is reducing, it is going to reduce the blood supply of the kidney also. So that will lead to pre-renal acute kidney injury, right? So remember about this. Whenever it is going less than 60, it is poor perfusion. Remember, it has to be maintained within the rate of 70 to 100 mm of Hg, right? So this, if it is going to be less than 60, it is going to cause renal failure, acute renal failure, and primarily, to be very specific, you have to remember pre-renal, which means the problem is before the kidneys. The problem is before the kidneys, which means the kidney is not getting adequate amount of blood supply, so it is leading to acute kidney injury. Next is your cerebral hypoxia, shock. All these things happens because of your reduced mean arterial pressure, which means reduction in the circulating blood volume, right? Next, we're going to see about the next question. A 55 years old male present to the emergency department with hematemesis, melena, and coffee ground gastric aspirant, right? So what is the first line pharmacological treatment to be initiated for suspect under gastrointestinal bleeding while awaiting for endoscopy? Now, classically, give me the answer. a 55 years old male patient. Okay, he's coming to the emergency department with hematemesis, melena, and coffee ground. Yes. Pavandeep, you're telling C. Can you give me the justification why you are giving C, intravenous octreotide, as an answer? So remember, there is no certain specification that it is a case of variceal bleeding. As you all know, intravenous octreotide is a drug of choice in case of your variceal bleeding, as you all know. It's a drug of choice for your variceal bleeding. Right? Which happens because of what? Because of your portal hypertension. Remember? Portal hypertension. Right? So that is the drug of choice in case of your variceal bleeding during, which happens because of portal hypertension. And the most important thing is you have some close correlation, because octreotide will be also given in case of the upper gastrointestinal bleeding, right? So how we can correlate with our question? Remember, the patient is having hematemesis, active bleeding in the vomiting, which means bleeding is in the upper GI tract, and melena, black tarry stool, and coffee ground appearance in gastric aspirants, all are telling there was a bleeding which is happening in the upper GI, right? And the previous bleeding is also there, which is giving these particular presentations. So we are concluding it is a case of upper gastrointestinal bleeding. So before sending the patient for endoscopy, okay, before we are performing the endoscopy to identify the actual diagnosis, first and foremost, to reduce the bleeding, okay, and reduce the excess amount of gastric secretion, we are going to give intravenous proton pump inhibitors. As some students have said, Aparna, Anu, very good. We are going to administer the patient with intravenous proton pump inhibitor. So what is the specific action of this intravenous proton pump inhibitor administration in case of upper GI bleeding? So this particular action of this drug, as you all know, it is your hydrogen potassium ATPase pump inhibitor. It inhibits hydrogen potassium ATPase pump, right? So when this particular inhibition is done, what it is going to do? It is going to raise the gastric pH. What it is going to do? It is going to raise the gastric pH. Okay. At what rate this is going to raise the gastric pH? Of greater than 6. Right. It is going to, you can actively put your comments in chat box also. I'll answer it. Right. So it is going to raise the gastric pH greater than 6. Okay. And it is going to produce an alkaline environment to your stomach. So if it is going to give an alkaline environment, as you all know, when the pH increased, it is going for alkaline, right? So alkalosis, you are going to tell when the pH is increasing, which means, remember about Hulk, pH is getting big, so it is alkalosis, right? So pH is getting higher, so alkalosis is happening. When you're giving an alkaline environment in your gastric area, it is reduce risk of bleeding, reduce the risk of rebleeding. Thereby, you're giving a very good management to your patient to get rid of excessive bleeding. Okay, and this particular proton pump inhibitor also helps in promotion of platelet aggregation also at the ulcer site, so that when there is a platelet aggregation, as well, it is going to enhance the hemostasis, right? Right. So many people are answering octreotide, but there is no specific finding is given that the patient is going for variceal bleeding. And here you have to see this key term also while awaiting for endoscopy. So you need to understand, right? What is oral sucralfate? A barrier for your ulcer sites, but it is not an immediate management, and it is not having any reduction, like it is not going to cause any form of hemodynamical stability also. So that is not a case which you're going to give to this particular patient. And what about oral antacids? Nobody has answered about oral antacids. Well and good. Like it is for neutralizing the gastric acid. So you're not using it for reduction in the bleeding. But remember about this intravenous proton pump inhibitor. When you're going to administer for the patient with upper gastrointestinal bleeding, this is going to have a lot of effects, not only reducing the acid, like it is going to raise the gastric production. Okay, gastric production of acids, and it's going to maintain the pH to be greater than 6. If the pH is going to be maintained greater than 6, it is giving an alkaline environment to the stomach. And when there is an alkaline environment, it is going to reduce the risk of rebleeding. And this particular proton pump inhibitors also promote platelet aggregation, whereby the actual bleeding, where it is there, it can promote hemostasis. Right? So the correct answer is intravenous proton pump inhibitor administration. Right? Next question. So is a classic early symptom of Parkinson's. Now tell me, you all know about all the Parkinson's related signs. Okay, you all know about Parkinson's related signs, but you'd have to tell me, like, what is the classical early sign? Come on. So before that, it is very, very important to know about the baseline data about what is Parkinson's. As you all know, Parkinson's is a neurodegenerative disorder, specifically a progressive neurodegenerative disorder with dopamine deficiency, substantia nigra, as you all know. Right. So now tell me, what is the early symptom of this particular progressive neurodegenerative disorder? Yes. I'm waiting for your answer. A. Oh, very good. Zaire, very good. So resting tremor is considered to be the earliest symptom and classical symptom of your Parkinson's disease. And now tell me, these active students, very good, Bhavika. Now tell me, what is the frequency of this particular resting tremor? What is the pattern of the resting tremor? What is resting tremor? Tremor occurs when the patient is resting. Okay. So when the patient is sitting simply at a place, the tremors is going to get increased. And if he is going to do some of the voluntary activities after seeing the tremor will subside subsequently. Okay. It decreases with voluntary movements. Right. The characteristics of the tremor, which includes your pill rolling. Very good. Very good. Additional informations are learned with the help of active students. Right. They are putting in comment boxes. Right. Remember, the characteristics of this resting tremor is pill rolling tremor. Right. Pill rolling tremor. And you all know he will be using the thumb and index finger movements. Thumb and index finger movements they will be using. And that's how this resting tremor can be classically visualized. And the frequency where the question is asked. What is the frequency of these tremors? It is 4 to 6 hertz. Okay. The frequency of these tremors is very good, Aparna. It's 4 to 6 hertz, right? And these tremors usually happens unilateral at one particular site. Okay. And this is considered to be the first and foremost noticed symptom, okay, of a patient with Parkinson's disease. Now tell me, what about the postural instability? Postural instability, when you can see postural instability? Okay, it is a late symptom. Okay, in case of advanced Parkinson's disease, okay, that is the postural instability can be seen. This is a late symptom. Okay, and this is the reason why this Parkinson's patient fall. Okay, highest risk of fall and gait disturbance will be there for this particular postural instability, which is related to Parkinson's disease. Next is severe cognitive impairment. Here we have to learn about this PDD condition. What is this PDD? That is your Parkinson's disease dementia. Okay, that is your Parkinson's disease dementia. Okay, this is otherwise in shortly termed as PDD. Right. This is also considered to be one of the late symptom. Right, remember about this. And this particular Parkinson's disease dementia, which is causing severe cognitive impairment, it is associated with your Lewy body deposition, which happens in Parkinson's, right? A cortical Lewy body deposition is again a classical important key point you have to remember while you are studying about this cognitive impairment related to Parkinson's disease, right? What about dysphagia? Like involvement of the bulbar muscle, okay, where you have impaired coordination. So that's why dysphagia is occurring. And if dysphagia is there, okay, difficulty in swallowing, dysphagia is there, it is going to cause severe form of asthma risk and malnutrition in other cases. So what are the other classical signs you can see in case of Parkinson's? Any idea? Right? So if you talk about the early symptoms, remember resting tremor, cogwheel rigidity, bradykinesia, micrographia, okay, hypomnia, right, muscle face appearance, okay, hypomimia, and anosmia, which is motor, which all happens in the pre or earlyly you can see this particular causes. Okay, sorry, earlyly you can see these particular symptoms. So in late cases, you have to remember postural instability, freezing gait, dysphagia, cognitive decline, autonomic failure, dementia, which is related to your Parkinson's disease dementia. These all are the late symptoms. These all are the late symptoms. Very good. Okay. Remember, early symptoms are, let me write it down. Early symptoms. Early symptoms are resting tremor, bradykinesia, and your rigidity, that is otherwise your cogwheel rigidity, to be very specific. Then micrographia and hypomimia. So hypomimia, like masked face appearance, will be there for this particular patient. And what are the late features? In late features, remember your postural instability, freezing of gait, dysphagia, okay, which is given in our option, along with that cognitive decline, and which leads to dementia, which is associated with your Parkinson's disease, disease dementia. And along with that, it is going to also have autonomic failures. Right? Additional pointers you can remember while studying about this Parkinson's disease. The most characteristics early symptom is what? Resting tremor. This is very, very important that you people have to note. So next question, which of the following is considered a late sign of acute compartment syndrome? Yes, I'm waiting for your answers. Please put in the chat box, right? What is the late sign of acute compartment syndrome? They are asking this question. Yes, actively waiting for your answers. In compartment syndrome, you see various P's, right? First is pain. Okay, pain which has happened due to ischemia, right? B. People are answering B. What is the late sign? I'm asking about what is the late sign of compartment syndrome? Yes, Aparna, Irish, Ashik, Meena Kumari, Nishi. Sorry, Meena Kumari, no. C is the correct answer. Okay, Naveen Yadav, Ashish, very good. C is the correct answer. Yes, pulselessness is the late sign of your compartment syndrome, right? So first we will learn about this piece. First is pain, which is happening due to ischemia. Next is what? Paresthesia. That is the tingling sensation or numbness which is seen, right? Because of nerve ischemia, this paresthesia is going to occur. Next is pallor, right? What is the cause for pallor? Pallor is going to happen because of reduced perfusion, and paralysis is also a late symptom, okay, or late sign you're going to see. So even more late, a very late symptom is what? Your very late sign is your pulselessness. Is your pulselessness. Okay. So the answer is C. Pulselessness is the very late symptom of your compartment syndrome. Remember these things. This is the order of early is pain. Okay. And pallor comes at intermediate, and these things are late. Right? Yes. So here, the most important thing you have to remember is what is compartment syndrome? Okay, it is like a life-threatening emergency situation where then intra-compartmental pressure is going to get increased drastically, right? So if the intra-compartmental pressure is going to get increased, at what term I am telling the intra-compartmental pressure is going to get increased so much? At what point I'm telling it? Remember, when the compartment pressure is going to be greater than or equal to 30 mm of Hg, then I'm telling the patient will go for acute compartment syndrome. So if it is going to increased amount, like greater than 30 mm of Hg, what is going to happen? Okay, increased compartment pressure. This will reduce the this is going to reduce capillary perfusion. Network is not interrupted. Reduce the capillary perfusion. And once capillary perfusion will lead to ischemia, will lead to necrosis, then it will irreversible damage. Once it is going for necrosis, then it is a irreversible damage. Concept behind this. So the answer is pulselessness. We'll discuss the next question. Paget's disease of bone is also known as which of the following? These are the repeater questions of your AIMS MSc Nursing examination 2025. So Paget's disease in bone is also known as which of the following? So what is Paget's disease? It is a disease of, very good. People are coming, yes. Osteitis deformans is the other name, okay, of your Paget's disease. Very good. Himani, she cable, very good. Disease is a chronic focal disorder of bone remodeling. Okay, so what is the primary characteristics of this Paget's disease? Right. So there will be excessive osteoclastic activity. Okay, excessive osteoclast related bone resorption will be there. Okay, excessive osteoclast related bone resorption. On the other hand, so we have this osteoblastic events also. So what this osteoblast is going to do? If this osteoblastic effect is going to be there, osteoblast is also going to get activated, which is going to cause excessive bone remodeling, right? What it is going to do? It is going to do excessive formation of bones. Thereby, it is going to cause an deviation or deformity. It causes disorganized bone. So altogether, it is called Paget's disease. Remember why osteitis? Osteitis means it is bone inflammation, and deformance mean it reflects the bone deformity, which is happening because of both your osteoclast and osteoblast activity, right? So what is osteogenesis imperfecta? Come on, let's explore the distractors also. Remember, this osteogenesis imperfecta is a type 1 collagen related disorder. Okay, it's a genetic disorder because of your type 1 collagen defectiveness. Okay, it's a genetic disorder. So this particular type 1 collagen related disease is osteogenesis imperfecta. Along with that, we have this hearing loss is also a part of this type 1 collagen related defect, right? In the patient who is having this type 1 collagen defect, they will be having this hearing loss, osteogenesis imperfecta, brittle bones, and blue sclera, right? Remember that. And it is not at all related to your Paget's disease. And next is osteomalacia. As you all know, it is because of vitamin D deficiency, right? Vitamin D deficiency. What about osteoporosis? A very, very easy question. Okay, osteoporosis is otherwise known as your marble bone disease, and it is because of the defective osteoclast function. Okay, it is because of defective osteoclast function. So what it is going to do? It will make sure the bone is very dense, but it will be brittle. It breaks so easy. All right. So this is the concept behind this MCQ. So the next MCQ, which of the following is a classical clinical sign or laboratory finding associated with multiple myeloma? Yes, classically give your answers. Multiple myeloma. In multiple myeloma, which of the following classical clinical sign or a laboratory finding you can see? Come on, explore the question. So either you will see Benz-Jones protein or Reed-Sternberg cells or your Philadelphia chromosome or your Oyer rods. So first tell me, what is multiple myeloma? So multiple myeloma, as you all know, it is a proliferative, okay, malignant proliferative disorder where there will be excessive production of monoclonal immunoglobulins, right? So M protein production is going to be increased. Okay, along with M protein production, the excessive production of free light chains, right? Excessive production of light chains, which includes your kappa and lambda. Okay, kappa or lambda. Okay, kappa or lambda. So remember about this condition. So if this light chain is produced, excessive light chain is produced, what is the finding? Yes, very good. Zaire, very good. Aparna, very good. Nishi Agarwal, very good. Benz-Jones proteinuria will be seen. So the most important thing is, because many free monoclonal light chains are produced in case of your multiple myeloma abnormally in a proliferative way. Okay, this particular free chains, okay, as I said you, these particular free light chains are going to appear in the urine. Okay, these are going to appear in the urine in the form of Benz-Jones proteinuria. So why we are talking about proteinuria here? There is a classical clinical correlation you have to remember. Whenever these particular light chains are formed, these light chains are going to get accumulated in the glomerular basement membrane. Obviously, this is circulating in higher amount in the body. Okay, in the blood, this is circulating in higher amount. So if it is going to circulate in a higher amount in the blood, it is going to get filtered by the kidney only. In the process of filtration, what will happen? These light chains, okay, these light chains will go and deposit in the glomerular basement membrane where the filtration is happening. Okay, the fluid exchange, the filtration, okay, urea creatinine, okay, urea creatinine, absorption, reabsorption, everything happens in this glomerular basement membrane. So what will happen? This particular this particular chains will go and accumulate in that particular area. And if they are going to accumulate in that particular area, they are going to damage the basement membrane. So if the glomerular basement membrane is damaged because of these chains, these chains will also come in the urine. Along with that, what will happen? Proteinuria will also be there. As you all know, the large molecules or the medium-sized molecules will not be filtered by the kidney. Okay, thereby only RBCs will be entering back, and proteins in the form of albumin, they will be also entering back. When the basement membrane is damaged, what will happen when the basement membrane is damaged because of these chains? What will happen? There will be leak of albumin. Okay, albumin. Okay, which means in the form of proteinuria, you can see. And along with that, these chains are also released. So when these are released, you can come to the conclusion, you can see this active Benz-Jones proteinuria. The most important thing you have to remember is, whenever you study about multiple myeloma in correlation with CKD or AKI, remember the patient will be having proteinuria and hypoalbuminemia. Okay, and hypoalbuminemia. Right. We also have a CRAB criteria for this multiple myeloma, as you all know. What is this CRAB criteria? Tell me, what is this CRAB criteria for your multiple myeloma? So this CRAB criteria indicates the patient will be going for hypercalcemia because of which is going to have excessive bone resorption, and renal failure. As I said you, it is going to attach to the glomerular basement membrane and going to damage the renal cells, and it can also lead to anemia causing marrow infiltration, and bone lesions can also be caused by them. All right. So now tell me, Reed-Sternberg cells are seen in what case? Okay, so Reed-Sternberg cells are seen in what condition? As you all know, in Hodgkin's lymphoma, you can see this Reed-Sternberg cells. In Hodgkin's lymphoma. Right? So what about your Philadelphia chromosome? It is seen in case of your chronic myeloid leukemia. Very good, very good, very good. It is seen in case of your chronic, I'm seeing your comments here. Okay. Chronic myeloid. Very good. Chronic myeloid leukemia. Now tell me, in oil rods is seen in which condition? Fast. Philadelphia chromosome also you delayed a lot, right? Where you can see oil rods, needle-shaped inclusions in the myeloblast. Very good. Yes, chronic myeloid leukemia, you can see Philadelphia chromosome. Okay, that is T9,22 translocation, right? Now you have to tell me for oil rods. Very good. Acute myeloid leukemia. Very good. It is your acute myeloid leukemia. You can see oil rods. Nilya, very good. Very good. Yes, let's go to the next question. A patient develops sudden shortness of breath, tachycardia, and muffled heart sounds. Classical feature, very easy question. Sudden shortness of breath, tachycardia, and muffled heart sound. A recent myocardial infarction. And he is also a case of a recent myocardial infarction. Which of the following life-threatening complication is most likely indicated by these findings? Come on, tell me. I'm waiting for your answers. Very good. Bhavika, very good, Bhavika. What they are trying to tell in this particular condition, right? A patient is a case of recent myocardial infarction, right? Recently, he has admitted for myocardial infarction, and immediately he is expressing shortness of breath, tachycardia, and muffled heart sound, which is strongly suggesting the patient is going for what? Cardiac tamponade. What is cardiac tamponade? Accumulation of buildup of what? Fluid in your pericardial sac. So remember, what is the close association with our question? Whenever the patient is a case of recent myocardial infarction, what is the reason for cardiac tamponade? We know that the symptoms is telling it is a case of cardiac tamponade. What is the post-MI complication which is leading the patient to get cardiac tamponade? Remember, in post-MI, the left ventricular free wall rupture can happen. Okay, what can happen? The left ventricular free wall rupture can happen. Okay, this happens within 3 to 7 days post MI. Okay, this happens 3 to 7 days post MI. So when this rupture is happening, what suddenly the blood will be pooled, okay, accumulated in the pericardial sac. Okay, when excessive amount of this blood is accumulated in the pericardial sac, you are telling it as a hemopericardium, right? Hemopericardium, right? You are telling it is hemopericardium. Remember, when there is this rapid accumulation of blood into the pericardial sac is happening, it is going to increase the intrapericardial pressure, right? So ventricles will become small, okay? Heart will become small. The pericardial fluids will be accumulated here. The ventricle will become small. Okay, the ventricular filling will be very much reduced. So if the ventricular filling is reduced, overall surface area is reduced. Obviously, the cardiac output is also going to get reduced. So now tell me, what is a classical triad of your cardiac tamponade? What is the name of the triad? These are very commonly asked in competitive examination. It's your Beck's triad, right? It's your Beck's triad. So what are the components of Beck's triad? Remember, hypotension or low blood pressure. Okay, hypotension or low blood pressure. Then your muffled heart sound, as it is given in your question. Muffled heart sound. Very good, Zaire. Very good, Narmata. Muffled heart sound. Then the last one is raised JVP, jugular venous pressure. Raised JVP. So these are all the important aspects you have to study in MSc nursing entrance examination. Why I am reinforcing this particular point? Remember, children, for MSc nursing entrance examination and all, they are not going to ask you so classical, so difficult question. Mostly the questions will be memory based. Okay, mostly the questions will be memory based. So in most of the cases, like Beck's triad and all requires memory, like understanding come memory, but memory is very important. So memory based questions are very commonly asked in entrance examinations. So it is very important to have memory based questions and fingertips. What you have to do is plan MSc 5.0 you have in your hands. Definitely watch all this test and discussion videos and everything and complete the portion. Then start to give lot of test, because you're not going for theory examination, you're going for MCQ related examination. So it is very important to practice things. Okay, efficiently practice the papers. Give lot of mocks. See the previous papers. All the previous papers are available in the app. See all the previous papers, right? So check out everything and study properly. And once you practice lot of MCQs, what will happen? Ultimately, your practice will get improved day by day and you will be feeling so efficient to give the test. Okay, give your actual examination. And most important thing is, once you give the test, it's not like closing and just leaving. No. Once you give the test, whatever correct answer, you feel motivated and confident within yourself. So whenever there is an incorrect answer, go to the rational, study the rational. Okay, rectify your incorrectness. Just like that, don't study anything. Once you give the test, follow up is very important, right? So the next question. A patient present with normal arterial oxygen tension. Okay, the PaO2 is normal arterial oxygen tension, and but low saturation, SpO2 is called, right, is dropped. Which of the following is most likely the cause? Come on, now answer me. The dissolved oxygen in plasma is normal. That is explained in the form of PaO2. Okay, the dissolved oxygen in the plasma. But SpO2, the hemoglobin bound oxygen, is reduced. The hemoglobin bound oxygen is reduced. Now, what is the reason? Which of the following is most likely the cause? Yes, my actor students will give me will give the answers. Some people are answering A. I want the correct answer. Yes, correct answer. So see, listen, in case of high altitude, remember both drops. Your PaO2 also drops and SpO2 also drops. Here, the perfusing oxygen is not like normal. Okay, the PaO2 remains normal, which means the dissolved oxygen in the body is unaffected by the SpO2 is only falling. Okay, so what is the reason? Hemoglobin bound oxygen is only reducing. Again, people are telling A in attitude, both of your PaO2 and SpO2, right? Here, PaO2 is also going to reduce and SpO2 is also going to reduce. But here, classically, they are telling PaO2 is normal, but SpO2 is increasing. Sorry, SpO2 is decreasing. PaO2 is normal, SpO2 is decreasing. Yes, some students have given the correct answer. Aparna, Nishi, Pooja Mishra. Very good. Yes. Why this carbon monoxide poisoning is the correct answer. Now we are going to study about this. Remember, carbon monoxide is having more affinity. Okay. So it is having more affinity for your hemoglobin than oxygen. Okay. Your carbon monoxide is having more than 200 to 250 times affinity or love towards your what? Hemoglobin. So what will happen if carbon monoxide and oxygen, both of them are there? Okay, hemoglobin will catch CO only, that carbon monoxide only. They form this carboxyhemoglobin. As you all know, they form this carboxyhemoglobin. Right. So when this carboxyhemoglobin is keep on binding and it is formed because of this higher affinity towards hemoglobin, the carbon monoxide's higher affinity towards hemoglobin. So what will happen? The number of available hemoglobins, the HP available, hemoglobin available circulating will be reduced, obviously. Okay. So if the available hemoglobin is going to get reduced, oxygen binding will also going to reduce. So obviously it will lead to reduced in SpO2, right? So here the most important thing you have to remember, even though adequate amount of oxygen supply is there to the body, because of carbon monoxide is having excessive affinity towards the hemoglobin. What will happen? This hemoglobin is going to capture the carbon monoxide and keep it. But so what will happen? The number of HB is going to get reduced in the body. So when the number of HB is going to get reduced, what will happen? The binding oxygen capacity will also be decreased. Like when there are two friends, okay, one has to be taken by me, right? So me being a hemoglobin, I like carbon monoxide more. If both are available in front of me, I will take carbon monoxide more because carbon monoxide is having more affinity and more affection towards me, right? So same thing is happening even though there is adequate amount of oxygen supply, right? The perfusing oxygen is like the dissolved oxygen in the plasma is normal, but it is not utilized by the hemoglobin, right? So this is the reason why the SpO2 is falling and the PaO2 is remaining normal. And remember, in this particular condition, carbon monoxide poisoning, your oxygen dissociative curve will move in the left shift. Okay, the left shift of the oxy hemoglobin dissociation curve will be seen, right? Yes, remember this particular classical point also. So high altitude, as we discussed, the PaO2 and the SpO2 is going to get declined, right? So in case of COPD also, because of impaired gas exchange, the PaO2 and SpO2, we are going to have a varying, and there will be no normal PaO2 in this condition of COPD. So what about pulmonary embolism? Here also both are going to fall. Both are going to reduce. In pulmonary embolism also, both PaO2 and SpO2 are going to reduce, and this will lead to VQ mismatch. Okay, ventilation, perfusion mismatch, right? So the next question. A patient with immediate post-operative period following a radical mastectomy, which of the following nursing intervention is the most important to prevent complication related to the surgical site? Now answer actively. Immediate post-operative patient, okay, after radical mastectomy, okay, partial removal of the breast, and which of the following nursing intervention is most important to prevent complication related to the surgical site? Position the affected arm below the level of heart. Is it the correct answer? Yes, come on, give your answers. So when you're going to position the affected arm below the level of heart, what will happen? Okay, this is going to cause increased edema, okay, and lead to lymphedema, accumulation of lymphatic fluids over there. Encourage deep breathing and coughing exercise. Answer correctly. Arm should be elevated above the level of heart, as you all know, in order to have a proper lymphatic drainage. It should not be below the level of heart. Remember this small words: below, above, first priority, late, early sign. These words are very, very important to notice in competitive examination. You will lose marks because of this. Keywords, trap the keywords properly. They're asking for most appropriate intervention, or they're asking not factor or except factor, that you have to note, right? So if you're going to position the affected arm below the level of heart, it's going to cause what? Edema, right? Encourage deep breathing and coughing exercise. As you all know, the immediate post-operative complication, which happens within a day, within 24 hours, in day one, what is the most common cause? It is atelectasis. This is a very, very important classical MCQ. Okay, definitely this point you have to remember. The earliest post-operative complication which a patient can get. Nobody has answered B. Why? The earliest post-operative complication is atelectasis. So prevention of atelectasis is very, very important. What are all the things which we will do for preventing atelectasis? You have to encourage deep breathing exercises and coughing exercises and steam inhalation, cessation of smoking, right? And chest physiotherapy and incentive spirometry has to be definitely given to the patient. Applying a heat pad to the surgical site, no, strictly not advisable, right? This will cause bleeding. Risk of bleeding will be there. Allow dependent arm position to reduce swelling. Again, if you're going to do the dependent arm positioning, it is going to cause fluid accumulation. Opposite position is always recommended, right? Not a dependent position. Opposite position is recommended. Okay. Remember, encouraging deep breathing exercise in order to prevent the atelectasis is very, very important, right? So as I said, you immediate post-operative complication is your atelectasis. So in order to prevent that, we are going for this deep breathing exercises. Now tell me, in day 2 to 3, what is the most common post-operative infection? For example, I'll tell you, a patient is having post-operative fever. Post-operative fever, right? So if the patient is having post-operative fever, day 1, if the patient is having fever, what is the most important cause? Remember, atelectasis. Right? So we are giving the necessary management. If it is day 2 to 3, what is the reason? Remember, it is because of your thrombophlebitis. Okay? Any superficial thrombophlebitis is there. Okay? Then the patient will get a post-operative fever. In second day, in 2 to 3, this is the reason. And remember, UTI is one of the most common hospital-acquired infection, which is also again causing the what? Fever in 2 to 3 post-operative days. And again, pneumonia. So these are the reason for fever in day 2 to 3 of your post-operative session. Question is saying site. Okay. Question is having some minor error. Let me correct it. Okay. So the post, like coming back to our post-operative fever. Right. So here, day 1, you're going to go for atelectasis. In day 2 to 3, it is the reason of superficial thrombophlebitis, UTI, and pneumonia. In day 4 to 5, what is the reason for post-operative fever? In day 4 to 5, the reason for post-operative fever be completely surgical site infection. Okay, it is surgical site infection, or it may be deep venous thrombosis. Because of prolonged immobility, the patient can go for DVT also. Right. If it is day 6, the patient is having excessive fever. So it is because of burst abdomen or abdominal wound dehiscence. Very good, very good. Many students are answering correctly. Dehiscence, right? Right. What if it is greater than or equal to day 7? Any answers from the students? What if it is greater than or equal to day 7? Yes. Intra-abdominal abscess or collection. If there is an intra-abdominal abscess or collection, then it's very good, very good, very good, very good. So if it is going to be intra-abdominal abscess or collection, then it is related to day 7. So what about wound infection within 30 days of surgery? So when you are telling it is a surgical site infection, just now I have said the key point. Surgical site infection means the wound infection happens within 30 days of surgery. Wound infection happens within 30 days of surgery. It's called your surgical site infection. So when you are telling, very good, SSI within 30 days. What about post-implantation surgical site infection? In case of post-implantation, when you are telling it is a surgical site infection. Post-implantation surgical site infection, when you are telling post-implantation SSI. Any answers from the students? Yes, within 1 year of surgery, if there is an infection in the implantation, then you're telling it is related to the surgical site infection, right? So let's go to the next question. A post-operative patient suddenly develops shortness of breath, tachycardia, and pleuritic chest pain on post-operative day 2. Which of the following is most likely the clinical diagnosis? Again, just now we have seen this. Now tell me, what is the answer? Very good. Many people are answering correctly. Now tell me, a post-operative patient suddenly develops shortness of breath, right? And he's having tachycardia, shortness of breath, and pleuritic chest pain in day 2. What is most likely the diagnosis? Yes, answers. Classically see the symptoms: pleuritic chest pain, shortness of breath, tachycardia. Yes, very good. It's your pulmonary embolism. The classical features of pulmonary embolism is clearly given in the question, right? Sudden dyspnea, that is termed as your shortness of breath, tachycardia. Okay, it's a very, very consistent and earliest sign for the patient. And you also have this pleuritic chest pain. What is meant by pleuritic chest pain? A sharp worsening chest pain, which is so much worsened, especially on inspiration, right? So obviously these patients is going to have lot of ventilation and perfusion mismatch. So now tell me, if the patient is a case of pulmonary embolism, what is the gold standard diagnosis, like diagnostic technique? If the patient is a case of pulmonary embolism, what is the gold standard? What is the gold standard diagnostic technique? Any answers? Remember, CT pulmonary angiography is the gold standard investigation technique. Pulmonary angiography is considered to be the gold standard diagnostic methodology which is used for the diagnosis. And you can also see elevated D-dimer. Okay, ABG will be showing what? Low PaCO2, and the patient will be going for respiratory alkalosis. Right? Yes. Now tell me, atelectasis, as I said you, mild dyspnea patient will be having, and the patient will be definitely having fever. Okay. So in case of atelectasis, what is meant by atelectasis? Hypoventilation because of mucus plugging, right? Hypoventilation which happens because of excessive mucus plugging, right? So breath sounds will be diminished on auscultation in case of your atelectasis, right? But all the symptoms which is given here is telling most common is pneumonia. See, here remember children, here this is the reason for post-operative fevers. In post-operative, these are the following conditions can happen, and that is the reason for post-operative fever. Right? We can n number of complications we can have in post-operative period. But remember, fever, specifically fever is happening, then you're classically telling it may be because of in day 2 or 3, if it is happening, it may be because of superficial thrombophlebitis, UTI, or pneumonia. Okay, I'm trying to tell that. But here you can see classically the pleuritic chest pain is there, right? So that will be the primary reason that the patient can be clinically diagnosed as pulmonary embolism. So atelectasis is the mucosal plug, as I said you. Then what about myocardial infarction? Chest pain, tachycardia, squeezing type of substernal chest pain will be there in case of your what? In case of your myocardial infarction. So what about pneumonia? Pneumonia can also cause pleuritic chest pain, okay, and dyspnea, but it is a gradual onset. It's not a sudden onset. It is a gradual onset, okay. And along with that, if there is a word of fever here, okay, then you can definitely go for pneumonia. That's what you have to understand. Like one or two words is going to change the question's answer. Okay. In case of your pneumonia, the patient will be having what? Pleuritic pain and dyspnea, which is very gradual in onset. Okay. And fever, productive cough. Okay, productive cough the patient will be having. And the most important lung findings, what are they? Crackles and bronchial breath sounds will be here. Crackles and bronchial breath sounds will be here. So these are the classical features which is differentiating your patient from pulmonary embolism and pneumonia. Very good, very good. Yes. So let's go to the next question. A 55 years old woman present with fatigue, bone pain, constipation, and polyuria. Fatigue, bone pain, constipation, and polyuria. Laboratory finding reveal elevated serum calcium and elevated parathyroid hormone. So patient is going for hypercalcemia as well as elevated parathyroid hormone. Right. What is most likely the diagnosis? Come on, put in the chat box immediately. Classically differentiate. A very like slightly confusing question, but if you think correctly, you can answer it. Elevated serum calcium and elevated parathyroid hormones. Many people are answering B, secondary hyperparathyroidism. Why you people are telling secondary hyperparathyroidism? Secondary means what? Which is because of other condition. Your secondary hyperparathyroidism is associated with your chronic kidney disease, right? It is associated with your CKD. The most important part you people have to remember, right? So what is the part you have to remember is PTH is elevated. Okay, in case of secondary hyperparathyroidism, parathyroid hormone will be elevated, but the serum calcium level can be low or normal. Okay, in secondary hyperparathyroidism, that you people have to remember. So here, hypocalcemia happens because of vitamin D deficiency. As you all know, one of the important renal function is to activate vitamin D. Vitamin D activation will not be happening properly if the renal failure is there. If vitamin D is deficiency is there, intestinal absorption of calcium will also be reduced. So in case of secondary hyperparathyroidism, which is happening because of any secondary condition, for example, if you talk about CKD and everything, what is going to cause? It is going to cause either normal or low calcium level along with increased parathyroid hormone, right? And later it leads to hypercalcemia. That is a different pathophysiology you have to learn. That is an advanced pathophysiology you have to learn. But here we have the answer already. The calcium level is also elevated, right? And the parathyroid hormone is also elevated. So it is a primary hyperparathyroidism. Okay, this primary hyperparathyroidism means the problem is within the parathyroid gland. If there is a parathyroid adenoma, the most common cause of your primary hyperparathyroidism is your parathyroid adenoma, which is causing 85% of the cases, right? If there is parathyroid dysplasia or if there is parathyroid carcinoma, that is a rare condition. But remember, parathyroid adenoma is the most common cause, and which is the 85% of the cases are from this parathyroid adenoma only. Then it's hyperplasia or parathyroid carcinoma. It's a rare condition, right? What will happen? Excessive PTH, what it is going to do? Increases the serum calcium because of bone reabsorption. Excessive parathyroid hormone will be produced, sensing that the calcium level is very low in the body. So what will happen? This will excessively create bone resorption, activation of the osteoclastic activity. Excessively, what bone resorption will be done, and excessive calcium will be released from the bone. What is going to cause? This is going to cause the damage to the bone itself, right? If it is going to go for hypercalcemic state, what will happen? The renal calcium reabsorption will be there. Excessive calcium will be there. Excessive renal calcium reabsorption will be also there, right? So remember these particular aspects. Secondary hyperparathyroidism, remember about the CKD's correlation, and hypercalcemia of malignancy. Here, hypercalcemia of malignancy specifically will be having high calcium rate, but parathyroid hormone will not be higher, right? Remember that. And what about hypoparathyroidism? In hypoparathyroidism, there will be low parathyroid hormone and there will be low calcium. Both PTH and calcium is going to get reduced in case of hypoparathyroidism. And here where you can see this Shostak's and Troisi's sign, right? Muscle cramps because of hypocalcemia can also be seen in this hypoparathyroidism state. Remember, in primary hyperparathyroidism, you'll be having higher amount of calcium and higher amount of parathyroid hormone. This higher amount of parathyroid hormone is going to stimulate bone reabsorption. Thereby, it is going to release a lot of calcium and showing hypercalcemic effect, right? Yes. And this is going to stimulate vitamin D also. As I said, if vitamin D is inadequate number, what will happen? Vitamin D will induce intestinal absorption of calcium, right? So that will happen in hyperactive form in case of primary hyperparathyroidism. In secondary hyperparathyroidism, it is because of external conditions like CKD and other conditions, especially CKD, you have to remember the correlation. If CKD is there, active vitamin D will be very much reduced. If active vitamin D is very much reduced, intestinal calcium absorption will be disrupted, will be reduced. But in later stages, the patient will go for hypercalcemia because of this secondary hyperparathyroidism effect. But initially, the patient will be on low calcium, right? Remember that. Yes. So next is a nurse inadvertently administer the wrong dose of prescribed drug to a patient, but identifies the error immediately and reporting it to the supervisor. According to the standard safety guidelines, which of the following action best reflects the appropriate nursing response to medication error? So you have done a medication error, what you will do? Now tell me. You have done a medication error, what you will do? Document the error in your personal notes, but not in the patient record. No, very wrong approach. Just noticing within yourself and enjoying. No. Notify the physician, monitor the patient, and complete an incident report. Yes, obviously we'll be doing this. Let's see other options also. Report the error only if the patient shows adverse symptoms. No, this is ethically wrong. Ignore the error if no harm occurred to the patient. This is also ethically wrong. But what actually we will do? What as a nursing student or as a nursing officer, what actually you will do? Okay, you will not report the error. Also, you will not do anything, right? You will just ignore the error if no harm is occurred to the patient. If at all something is abruptly happening to the patient, then you can come forward, or else you will not tell. But it is not ethically correct. Remember, whenever you have done any mistake, it is very very good. First, monitor the patient, which means here, remember, when this particular option is there, assess the patient. Okay, before reporting everything, you have to assess the patient. See the order. First is assessing the patient, then notifying the physician, then you have to do an incident reporting. Assessing the patient is a primary important task which you have to do, because you have to watch if there is any abnormal events happened because of your activity of medication error, right? So whatever ethically is correct, you have to do, even though the mistake is on yourself, accept it and go for it, so that better solution will be fetched, right? So the next question. Barrett's esophagus is a pre-malignant condition characterized by the replacement of normal squamous epithelium into the columnar epithelium in the distal esophagus. So this change most commonly occur as a complication of which of the following condition? Come on, answer fastly. If the patient is a case of Barrett esophagus, where the normal squamous epithelium in your distal esophagus is converted to columnar epithelium, okay, which means even more hard. It is becoming even more hard. It is replaced by the intestinal metaplasia or globular cells. So what is the mechanism, or what is the reason for that? Come on. In what case there will be excessive inflammation? Esophagitis will happen in what case? Remember. Yes, I'm waiting for your answers. So chronic is gastroesophageal reflux disorder. It's very good, Narmata. So in case of your GERD, because of excessive esophagitis, okay, subsequent metaplasia can happen. Okay, this is the primary concern which can lead to Barrett's esophagus. So next is peptic ulcer disease. Peptic ulcer disease, as you all know, it is primarily affecting the duodenum. It is primarily affecting the duodenum, and it is not affecting. Very good, very good. It is not affecting your esophagus, remember. Aclasia cardia. What is aclasia cardia? It is your lower esophageal motility disorder. Okay, lower esophageal motility disorder, where the lower esophageal sphincter will not relax or close efficiently, or it will be very much relaxed. Okay, it will be very much relaxed, which is going to lead to dysphagia. Okay, esophageal dilatation, overall dilatation of the esophagus will be there because of this aclasia cardia, right? So esophageal varices, dilated submucosal veins. Okay, usually because of what? Portal hypertension and liver cirrhosis, but it is not going to cause Barrett's esophagus. Yes, very good. Due to frequent relaxation of the sphincters. In esophageal varices, what is happening? Submucosal vein dilatation will be there. Okay, that happens because of portal hypertension or liver cirrhosis. in case of liver cirrhosis. So it is very, very important to know these particular classical aspects which you have to learn, right? So the answer is chronic esophageal reflux disorder. Now tell me, the nursing management questions are the favorite questions of your AIMS MSc nursing entrance examination, right? So now tell me, a manager is planning to implement Henry Fayol's principle of management to improve the efficiency of her nursing unit. According to Fayol, which of the following best describes the principle of unity in commence? Each employee should receive order from only one superior. There should be a clear division of work among employees. Authority and responsibility should be balanced. The interest of organization should prevail individual interest. Now tell me, what is the principle which is followed here? Yes, obviously. Unity in commands means, remember, unity in commands means I am one leader, one command. All the people are following that one particular command only. Everyone is following that one particular leader only. So remember, in Henry Fayol's 14 principle, each and every principle is very, very important to learn. At least you will get one question from that 14 principles. Right? Understanding the meaning of the principle is very important. The most important thing is unity of commands. One leader, one command, and everyone is following that. What if there is multiple leaders, multiple commands? This is going to cause a disorganization, okay, within the organizational setup. So there should be a clear division of work. What principle it is telling? Division of work is the principle here. Every employee has to be assigned with a task based upon their capability, their efficiency, their experience, and expertise. Just like that, I'm not giving the task to Nishi Agarwal, right? Sorry, Nishi Gavel. Just like that, I cannot assign the task to Nishi Gavel, right? I have to understand her proficiency, her expertise, her competency level. Then I have to give the task to her. Next is authority and responsibility should be balanced. Remember what is meant by authority? Authority is the decision-making power. Authority is what? It's a decision-making power. I'm having that authority to order something to you, right? I can delegate a task to you. I can give instructions to perform that particular task to you. And what is meant by responsibility? Even though the task is done by my subordinates who is under me, the primary responsibility of the task, and I am accountable if something is going right or something is going wrong, right? Remember, while you are delegating, okay, while you are delegating anything, okay, while you're delegating anything, remember, as a leader, even though you are delegating the task to someone else, the primary responsibility of the task will be shifted towards the leader only. If something happens in nursing college, the principal will be the answerable person to the university, not the tutor or not the student, right? So that is the concept behind authority and responsibility. Authority is the decision-making power, whereas responsibility is taking up the active participation of the outcome. So the interest of the organization should prevail over the individual interest. This is talking about the subordination of individual interest, right? Subordination of individual interest means what? I work in an organization. I have interest in certain things. I would like to be a nurse entrepreneur, but it is not possible. I am working in an organization. I have to follow their goals. I have take up their goals as my goal and I have to work on it because they're paying me. Okay, you have to subordinate the individual interest to general interest of my organization, right? So that is the concept behind. Some people has commented chain of comments. What is chain of comments? Chain of comments is how the communication is flowing within the organization, right? If some circular is coming, it is coming from the principal to the HOD, HODs to the associate professors, then the assistant professors, then the tutors, and then it will be reaching the students. That is the chain of comments, how the communication is going. Sorry, that is called as the scalar chain, how the communication is going in between the organization, right? So next, tell me, a woman weighing 58 kg has second degree burns covering 20% of the total body surface area. Which of the following formula should be used to calculate the amount of fluid which has to be given? Yes, come on, this is a very, very important question. Yes, clear hierarchy. Now tell me, The classical students, I'm checking you people whether you people are updated with the knowledge regarding burns. Second degree burns, which is covering 20% of the total body surface area. Which of the following fluid resuscitation formula you should use? I'm waiting for your answers. People are answering C. No. See, remember, the formula has been updated. The Burns fluid resuscitation calculation formula has been updated. Right. When it is okay, remember, when it is second or everyone is answering C. Just hold on with me. I'll tell you the correct answer. C is not the correct answer. C is not the correct answer, dear children. I'll give you the answer. See, updated. The formula is updated. Please be with me. So second or third degree burn. Okay, third degree burns is there to a patient. Okay, this is the I'm writing. This is the category of burn. Okay, this is the category. Right? I'm writing the age also, and I'm writing the formula. Okay, the formula, which means amount of ringer lactate I should administer. Okay, and I'm writing the urine output, target urine output. Right? So this is very important update. Definitely update with the formula. So second and third degree burns. Okay, our patient is second degree burns. And if he is an adult patient, okay, if she is an adult patient, the formula has changed to 2 into weight in kg into your percentage of total body surface area. Okay, percentage of burns for total body surface area. Right? Okay, percentage of burns in your total body surface area. This is the formula. And the expected urine output is 0.5 ml per kg per hour. Right? The target urine output. So now tell me, what is the answer for our question? Percentage of burns into weight in kg into 2. 2 times this is repeated. We'll consider. Yes, no, it's not. It's correct only. Yes, tell me. Now the answer is what? Yes. Percentage of burns into weight in kg into 2. Okay, if you multiply it, however, it is going to give the same aspect only. Okay, then, so if the patient is less than 14 years, if the patient is less than 14 years, adult patient, it is 2 into weight in kg into percentage of total body surface area. If the patient is a 14 years old patient, then it is 3 into weight in kg into your percentage of burns. Okay, right? If the patient is less than 1 year, or less than 30 kg, then the formula is what? 3 into 3 into weight in kg into the percentage of total body surface area plus 5% dextrose at maintenance. Right? So here, for this 14 years patient, or the expected urine output is 1 ml per kg per hour. And here, less than 1 year and 30, the same 1 ml per kg per hour, 1 ml per kg per hour for both the cases. Okay, for both these cases, the same formula is there. Right? So again, we are using that formula of 4 into weight in kg into your total body surface area, where we are using that formula. Come on. When the patient is a 4th degree burn patient, or if it is an electrical burn, irrespective for the degree, it is an electrical burn, right? For all age groups, the formula is what? For all age groups, the formula is 4 into weight in kg into your percentage of total body surface area. And the expected target output is what? 1 to 1.5 ml per kg per hour. Until urine clears, we are going to give this particular dosage only, right? The amount of ringer lactate solution which you are going to give for 24 hours in ml, the formula has been changed and updated. Remember, for second and third degree burns, when it is an adult patient, 2 into body weight in kg into your percentage of total body surface area. And the most important thing is the urine output maintenance. It is 0.5 ml per kg per hour. So if it is less than 14 years patient and still it is 2 to second or third degree burns, it is 3 into weight in kg into your percentage of total body surface area. If it is less than 1 year or the weight of the patient is less than 30 kg, the same formula, 3 into weight in kg into your percentage of total body surface area plus 5% dextrose you're giving on maintenance weight, right? And the expected urine output is what? 1 ml per kg per hour, right? So if it is a fourth degree burn, remember fourth degree, and the formula also remains 4 only. 4 into 18 kg into your percentage of total body surface area. And remember, the urine output expected is 1 to 1.5 ml per kg per hour, right? So it's always the fluid requirement is what? 24 hours you're calculating. Half of the volume infused in 8 hours, right? Half volume infused in 8 hours, as you all know. And rest of the half volume will be infused for what? Next 16 hours. Rest for next 16 hours. Right? First degree burns, you're not giving any fluid resuscitation. Right? Yes. So the next question. A patient with sustained atrial fibrillation was given Parent. Okay, cover. What is the primary mechanism of action? Come on, tell me. See if they are given anticoagulant, you might have ticked it. Right? So what is the answer here? Just tell me. Sustained atrial fibrillation. You know that these patients or highest atrial fibrillation patients are at the highest risk for thrombus formation and embolization, right? So that's why we are giving this particular heparin. Now tell me, what is the action of it? Answers? I'll give you a clue. I'll give you a clue. Okay. I'll give you a clue. Just tell me. It is related to antithrombin, either activation or inactivation. Activation of antithrombin or inhibition of antithrombin. See, remember children, classically understand this. So heparin works on the principle of first it will activate the antithrombin 3. Okay, first it will activate the antithrombin 3. So once it is activating to antithrombin 3, okay, it will inhibit. Okay, it will inhibit the coagulation by inhibiting the thrombin, that is factor 2A and factor 10A, right? Factor 2A and factor 10A, inhibition will be there. What is there? Inhibition will be there. Directly it cannot act. Okay, directly it cannot act. But what it will do is, it will go and activate the antithrombin 3. with the help of this activation of antithrombin 3, it will go and actively inhibit factor 2A and factor 10A. Right. So the most important MCQ pointers I would like to tell you is we have various classifications, right? For this indirect thrombin inhibitors, right? This unfractionated heparin, low molecular heparin, fundoparinax, these are all what? These are all yes, am I audible, right? Yes. So these unfractionated heparin, low molecular weight heparin, fundoparinax, these are all indirect thrombin inhibitors. Okay, they cannot directly go and act on thrombin. What they are going to do, they are going to activate the antithrombin, then they will go and act on inhibiting this factor 2A and factor 10A, right? So what will happen here, the most important thing you have to remember, we have three components: unfractionated heparin and low molecular weight heparin, and we have, okay, so low molecular weight heparin and fondaparinux. Okay, fondaparinux. So unfractionated heparin, they inhibit factor 10A. Okay, they are inhibiting factor 10A and factor 2A. Both are inhibited in equal amount. So what about low molecular weight heparin? They inhibit factor 10A greater than factor 2A. Right? Active form. A means active form. Right? Fondaparinux, when you talk about fondaparinux, they have a generalized action. Okay, it is a pentasaccharide, no action on factor 2A, but it is only acting, only it will inhibit the factor 10A. It has no action on this 2A, right? It will be only inhibiting 10A. But you have to remember 10A and 2A are equally inhibited here. It is greaterly inhibited here, and it is only mechanism fondaparinux is working. So remember here, for exam purpose, what are all the things you have to monitor, right? So here, when you're administering fractionated heparin, then you have to definitely monitor APTT. You have to monitor APTT. And what is the risk of heparin-induced thrombocytopenia? It is very high in unfractionated heparin. It is lower in low molecular weight heparin, and it is very least in fondaparinux. This is again an MCQ point that you have to remember for your examination. Right? Right? So risk of osteoporosis is high with unfractionated heparin, but also you have to understand. So what is the time? Okay. Let's see this last question. Okay, we'll see this last question and we will wind up the session. Okay. So commonly preferred artery for ABG assessment in OPD setting is what? Now tell me, commonly preferred artery for ABG assessment in OPD setting. Some patient is coming. Am I audible? Yes. The commonly preferred artery ABG assessment OPD is. Yes, tell me. Yes, radial artery. And what is the optimal wrist angulation? The optimal, this is an NORCET MCQ. Optimal wrist angulation. Yes, very good. Optimal wrist angulation for radial artery. Anybody can answer? It's 45 degree. When you place the radial artery at 45 degree, it is going to become more superficial and more stable. It will not become more mobile. So it is very easy to prick and aspirate the sample effectively, right? So rest of the MCQs we will discuss in next class, and thank you everyone for staying with me. Okay, I hope you have learned something. Very good, Tanya, very good. I hope you learned good MCQs from this, the previous year AIMS MSc Nursing entrance exam questions. So Stay tuned for the other live sessions. I would like to share, I would like to ask you the feedback about the class, add in the comments, add in the chat box. I'll see it. Okay. Thanks for watching. Thank you so much. Bye bye. Bye bye, Ames. Bye bye. Yes. Thank you. Thank you so much, Tanya. Thank you. Thank you, dear. Thank you. Okay, the paper format. So AIMS MSc nursing entrance examination is going to have 90 MCQs, dear children, right? It is a combination of all nursing syllabus, and mostly it will be having weightage for nursing management, education, and research questions, along with all other important subjects. And you have to remember negative marks is also there. Remember that too, right? So cautiously, if you're going to practice all the clinical based MCQs and all the memory based MCQs, which is available in Plan MSc, then definitely the success rate is higher. So practice as much as MCQs possible, and maximal mock test you try to give, right? So since you have only 2.5 months solidly, do it effectively. Definitely you can score it. And remember, competition is tougher because many people are applying and many people are writing. But strategic preparation, if you're practicing good amount of MCQs, I know lot of people have selected by using Plan MSc 5.0. The test, the content is more than enough to achieve your seat in AIMS, right? So definitely with confidence, with self-belief, right? You just go for it. Definitely you people can achieve it, right? Thanks for watching. Bye-bye. Take care. Have a nice day and all the very best for your upcoming AIMS MSc Nursing Entrance Examination.